Welcome to the Clean Starts Here Responding to Norovirus webinar. As you're coming in, we're going to have a quick poll as we're waiting for everyone to join. Let me get that started. So welcome everyone. As you're coming in, feel free to take part in a little fun poll as we're waiting for everyone. Which of these would you rather receive for Valentine's Day? A romantic dinner where the chef actually uses a food thermometer? A bouquet of color-coded cutting boards? A heart-shaped container of properly stored leftovers? A serenade about the importance of hand washing, or a handwritten vow to stay home when sick, especially with norovirus. So we'll give maybe like 30 more seconds for people to join and take part in the poll if they would like to, and then we'll get started. I see a few more people coming in. As you come in, we have just a little fun poll to get us started. We'll keep it open for just a few more seconds, so get in your answer if you would like to. Okay, 10 more seconds, everyone. Get your answer in quick. And here are the results. If you're curious, it looks like 36% wanted the romantic dinner where the chef used a food thermometer. 38% wanted that handwritten vow to stay home when sick. 22% wanted a bouquet of cutting boards. 9% the heart-shaped container of properly stored leftovers. And 6% a serenade about the importance of hand washing. Okay, so let's go ahead and get started. We have a lot to get through today. I'm Katie Weston. I'm the program manager for the Partnership for Food Safety Education. As we're going through the webinar, feel free to drop in comments in the chat. If you have Q&As, put it in the Q&A box and we'll address those at the end of the webinar with all the speakers together. CEU information, we will be putting the certificate in the chat box. We'll send it in a follow-up email and we'll also post it on the website. So lots of ways you can get that. If you're not familiar with the Partnership for Food Safety Education, we're a network of about 13,000 health and food safety educators, 40 partners, and federal liaisons that work together to put out trusted science-based health messaging around food safety. And we do this because every year, 1 in 6 people get sick from foodborne illness in the US. And to help tackle that issue of foodborne illness, we have a conference coming up, the 2025 Consumer Food Safety Education Conference. This is the only conference in the US dedicated to consumer food safety education. And that is March 13th through 14th in Houston, Texas. And right now we have 20% off registration until Valentine's Day. So if you're thinking about coming, go ahead and register. This is the week to do that. And now I will turn it over to Gina Kramer. Hi, Gina.
Hi, Katie. Thank you so much. And thank you, Partnership for Food Safety Education, for inviting us to participate in the first webinar of your 4 Actions to Food Safety, Clean. My name's Gina Nicholson Kramer. I've been in the food safety and quality industry for over 25 years, and I am part of the leadership group of AFDO's Healthy People 2030 Norovirus at Retail. And I am filling in for, you can see the slide says Lori Farmer from FDA and Beth Wittry from CDC, and I'm filling in for them this morning. So as we get started, next slide, please. We're going to give an overview of the AFDO, Association of Food and Drug Officials, Healthy People 2030, and look at that. And so as we look at the history, the Department of Health and Human Services initiated Healthy People in 1980, and their goal was to identify a 10-year measurable public health objectives with targets to monitor progress and motivate and focus action on. So to improve the public health. Healthy People 2030 is the current iteration and was developed in 2020. The initiatives can be found at healthypeople.gov. Next slide, please. So as we look at Healthy People 2030 and being launched in 2020, I don't think any of us will forget the year 2020. And so we really looked at all of this through virtual meetings and virtual gatherings. It was a framework based on recommendations by the Secretary's Advisory Committee on National Health Promotion and Disease Prevention Objectives for 2030. And so input was included from many food safety professionals because as the HHS looked at Healthy People 2030, we were all involved in foodborne illness and how to prevent foodborne illness. So food safety professionals from a variety of sectors, including public and private sectors or organizations, federal and non-federal subject matter experts. And you can find this framework online. It includes a vision, and a mission, foundational principles, and overarching goals, core objectives, and research and development objectives. All those things necessary to start an initiative. And so I'm going to read to you the vision and the mission just to give you an idea of how broad this effort is. So the vision is a society in which all people can achieve their full potential for health and well-being across their lifespan. Our mission is to promote, strengthen, and evaluate the nation's efforts to improve the health and well-being of all people. Next slide, please. So we'll start with an overview of how Healthy People, we'll look at food safety targeted goals. One was the reduction in foodborne illness caused by pathogens, and Katie already gave you the brief overview of those statistics. 1 in 6 people in the United States acquire foodborne illness every year. And so Healthy People 2030 focuses on preventing foodborne illness by improving food safety practices, much in line with what the Partnership for Food Safety Education does, and in line with what all of you spend your career on every single day. So as AFDO meeting was held in 2020, there were over 100 food safety leaders, and they came together and they discussed the changes needed. And so we looked at all different areas, and you can see that we looked at salmonellosis from poultry, Shiga toxin producing E. coli, that's what STEC stands for, from produce, Norovirus at retail. And so these work groups were put together. They've been doing great work. Salmonella and Poultry Work Group has been assisting the Coalition of Safe Poultry Reform with resources and expertise. However, they are facilitating their own discussions and preparations for poultry safety framework. And many of you may have been following this. We have seen since 2020 some food safety reform through USDA wrapped around salmonellosis and poultry. So their work is ongoing and has made some positive effects in the regulatory scope. The Shiga toxin E. coli work group under produce was a pause. So they made a pause in their work group, and it was pending some publications of FDA's Ag Water Rule. And since that rule, they have resumed their meetings. The norovirus at retail, which is what the three of us are from, was to reduce the number of outbreaks of infections caused by norovirus. We had a developmental goal. We had objectives to currently for under developmental status. We've been able to refine those. And so you can see what we're looking at. We look at reducing the number of norovirus outbreaks, created developmental objectives, and those offer an opportunity to explore high priority areas without reliable baseline data. And the reason that that statement is there is because norovirus is not a reportable foodborne illness disease. And so that data makes it very difficult to collect and to look at how it's being reduced. Also, focus on research and science to drive strategic direction. So that's what norovirus at retail is focusing on. Next slide. If we look at restaurants, what is retail? Restaurants are the most common outbreak location when it comes to retail. Norovirus is the most common pathogen. We see that it is responsible for upwards of 46% and higher of foodborne illness outbreaks every year, just depending on the year. And we are in the middle of norovirus season right now, which I know Leanne and Angie will talk to you about. Ill workers are most commonly contribute to these outbreaks. So we see this factor, and I'll have to say in the poll, I chose making sure that if you have norovirus, you stay at home. That would be my Valentine's gift I would want to receive, because I would not want to receive noro as my Valentine gift. Next slide, please. So norovirus in the retail settings, and we are going to talk, Leanne and Angie will talk about this in more detail, but there are FDA food code prevention measures currently, which the states adopt at different frequencies and have implemented at different timeframes. And that is to exclude ill workers, no bare hand contact with ready to eat foods, wash hands. You're going to hear us talk about wash hands, wash hands, wash hands all the time, and clean and sanitize surfaces. And you'll hear us talk about that today as well. So the challenge has always been implementation of employee health policies and practices. It is tough for employees to stay home when they're sick, when they work at an hourly rate, and if they're sick, they're not paid when they're sick in the retail food setting, most likely. Most companies have that policy, and so we see employees coming to work when they're sick because they do need the money. They don't want to miss the money. Next slide, please. As this work group was put together for Healthy People 2030, you can see that we have members from all different areas of the food industry, regulatory, federal, state, local. We have industry representation from grocery retail, restaurants, food service, sanitation providing companies, chemical providers. We have different associations, academia, and regulatory. And we do have consumer groups as well. So what I'm going to do right now is turn it over to two of our members of our norovirus work group. And Leanne Jacobs, I will turn it over to you first, and then I believe Angie follows you after that. Thank you.
And I'm going to actually ask Angie to start with the first few slides because those she prepared.
Okay, great. Okay, thanks. Next, please, Katie. Okay, so what are we going to talk about today? These are the learning questions. And so these are the 6 questions that you should be able to answer by the end of our presentation. So what is human norovirus? How is it transmitted? How do we control it? And a key piece with the cleaning focus is what's the difference between cleaning, sanitizing, and disinfection? When do we clean? When do we sanitize or disinfect? And very importantly, why you're here is what can you do to prevent norovirus infections? Next. Okay, so it can happen. And this was shared by Katie Rigdon of AFDO. This is an actual noro outbreak that took place in Minnesota. And it was associated with a high school hockey banquet, and 26 individuals were sickened. So at the banquet, it was catered by a local grocery deli, and during the epi investigation, they found no practices of concern. But during the investigation, it was reported that cookies were provided, and these cookies were sourced from a home bakery. The person who had baked the cookies had been ill with diarrhea and vomiting, but did not handle food for 24 hours after the symptoms resolved. So she was wanting to do the right thing. But upon investigation, it was revealed that her son, who was at home at the same time, had vomited in the bathroom. And the vomitus was cleaned up, but there was no disinfection. And then lastly, all the equipment that was used for cookie preparation was stored separately. So the moral of this story is it can happen, and even when you have good intent. Next, and I'm going to turn it over to Leanne to share the science behind what is, and then I'm going to just share a little bit about what is the problem. And these are 3 key take-home messages that you need to remember. And then Leanne's going to go into more detail about each of these. Neuro is very contagious, as we're seeing an uptick in outbreaks and cases. Food service workers often go to work when sick. Gina had already mentioned that. And 1 in 5 food service workers report working while sick because of employment and time off policies. And 54% of outbreaks involve food workers touching ready-to-eat foods with their bare hands. And very importantly, and what is going to be the focus of our talk today is norovirus is hard to kill. And it can survive on surfaces for up to 2 weeks and resist many common antimicrobials and hand sanitizers, aka hand antiseptics. Next, Katie. So Leanne.
Okay, so pass it off to me. I'm going to give you a quick primer on all norovirus that's relevant to this subject. This virus is a member of what's called the Calliciviridae family. I'm going to take you back to a little bit of your basic biology. Viruses are actually very, very simple, and they are not living. They're what are called obligate intracellular parasites, meaning they need a live cell or a live host cell in order to multiply. But once they begin to multiply, then they infect more and more cells, and that's what, of course, causes your symptoms. Norovirus itself is called a non-enveloped virus. It has a very, very simple structure. If you look at the red, blue, and green figure on the right, it has a protein coat, which is the red and blue part, and the blue and green part, and inside is a piece of nucleic acid. In this case, it's RNA, not DNA. And that's the entire structure of the virus. Very, very tiny, only about 25 to 35 nanometers in diameter. There are many, many strains of norovirus, but there usually is only one what's called circulating strain or epidemic strain. And that's actually what we're dealing with right now. I'll talk about that in a few minutes. Some very common features. It is transmitted primarily by the fecal-oral route, so fecal material getting into the mouth and then causing infection through the gastrointestinal tract. However, it is shed in vomitus, and we'll talk about that in a minute. It is a human-specific virus, so human norovirus does not infect animals, and animal noroviruses do not infect people. And while not really relevant to this conversation, it is important to know that you cannot cultivate or grow this virus in the laboratory. So that makes it really hard for scientists to work with it. Next slide. So it looks like my arrows didn't come through, but if you look at the picture or the diagram on the left-hand side, whoops, no. On the left-hand side, you can see that virus transmission is mediated by lots of different routes, okay? Directly from person to person, from foods, from contaminated drinking water, from contaminated surfaces, that's what fomites are, etc. And keep in mind that in almost all of these instances, the contamination source is human fecal material, whether it's the material from a single infected individual or whether it's sewage contamination, which is what would be most likely in something like drinking water. And you can see on the right-hand side that it shows kind of the complexity of the transmission patterns of human norovirus within human populations. Next slide, please. So what is the importance of each of these different transmission routes? Okay, so whatever person to person means, and that's a really vague term, but really the predominant mode of spread of human norovirus is person to person transmission. This is one of the reasons you see big outbreaks in nursing homes. You see big outbreaks in schools, for example. You see big community outbreaks. Um, However, about 25% of norovirus cases in the United States are transmitted by foodborne routes. And this is what we're going to focus on this webinar. Next slide, please. So what is this? This is a great quote about what the symptoms are flying out of both ends. The incubation period is usually about 18 to 36 hours from when you would consume a contaminated piece of food to when you would have the first symptoms. I will say that while vomiting and diarrhea are the primary symptoms of norovirus infection, vomiting is what is considered a hallmark symptom. So about 90% of people who present with norovirus cases will vomit, and it's usually very profuse vomiting, oftentimes called projectile vomiting. We now know that human norovirus is the leading cause of acute gastroenteritis around the world. So it is a really important cause of illness. However, it has relatively, certainly in high-income countries, relatively low hospitalization rates and mortality rates. So you've got a lot of cases, but the likelihood that they're going to lead to really major major health effects are low. Usually when you get the virus, you have it for a couple of days. I oftentimes say you feel like you're going to die, but you don't die. And most of us, I would say probably 80% to 90% of the population have at least had one norovirus illness in the course of their lives. If you look at US data that we have through estimates, and I'll talk a little bit about the epidemiology, we probably have in any one year between 20 and 25 million cases by all transmission routes. That does still result in about 70,000 hospitalizations and 800 deaths. But again, look at the number of cases versus the number of serious outcomes. You can see the likelihood of a serious outcome is pretty low. Of those, about 5 million are associated with the foodborne route of transmission. Okay. And if you look at the CDC data on foodborne disease in general, that means that about 15,000 food-related hospitalizations are associated with norovirus. That ranks it second in hospitalizations, and about 150 deaths are associated with noro, mostly in elderly and elderly people in association with foodborne routes, ranking it fourth in foodborne deaths. Again, keep in mind, this is driven not by high morbidity and mortality, it's driven by the sheer number of cases that we have. Next slide. Okay, so Gina mentioned that norovirus is not a reportable disease in the United States. So public health officials are not required or even really do report it to the CDC, and docs are not required to report it to their state public health officials. It is rarely tested for in primary healthcare. There are a few tests that have emerged. But if you go to the doctor with a norovirus case, and most people don't, most people just stay home. But if you go to a doctor, he or she will diagnose it based on your symptoms, not based on an official test like we have for COVID, for example. There are a few active surveillance systems in the United States that help determine things like baseline rates of infection, features of outbreaks. A lot of those, because it's not a reportable disease, are actually based on mathematical modeling. So they're essentially estimates. So while we have numbers and we throw numbers around pretty loosely, it's important to realize that the disease burden really for this particular illness is relatively poorly understood. Next slide, please. So there is an epidemiological surveillance system for norovirus called Norostat. It is run through the CDC. It is part of the National Outbreak Reporting System, or NORS. And NORS is really it's a reporting system that is generally voluntary, and it really covers mostly food, water, environmental types of sources of exposure and disease. And Noro is by far the biggest reporter within the NORS system. But what CDC has done is they've taken they have identified 15 states that report voluntarily through the NORS system, and they're asking them to report every norovirus outbreak that they have investigated in a timely manner. And a timely manner means a manner of a week or two. And then they're using that to track virus transmission in outbreak settings in near real time. And if you look at the left-hand side of this slide, you will see the NORS data from 2012 to 2025. And what I really want to point out is the red line, which are the number of norovirus outbreaks that we have seen this winter. And you can see there's a huge peak, right? And that peak is because we have a new epidemic strain circulating in the population right now. We also have increased susceptibility within our population because people have not really been exposed to this virus a lot during those years of the pandemic. So we've got a couple of drivers of the high numbers, but we are in an epidemic phase right now. The other thing I want to point out is that another name we oftentimes use for norovirus is winter vomiting disease. That doesn't mean it doesn't occur in other seasons, but when you see a peak, it's almost always in the winter months. Next slide. So what are the risk factors for enteric virus contamination of foods? I'm not going to go into detail on what the at-risk foods are. Suffice it to say that the three main categories seem to be mollusk and shellfish, produce, particularly frozen berries, and what we call ready-to-eat foods, which is what the retail norovirus team is looking at. Without a question, in developed countries or high-income countries, the retail food sector is of greatest risk for norovirus outbreaks. Okay, it is the most important food that is often associated with foodborne outbreaks. And Aaron Hall at CDC did a beautiful study where he took some data from that NORS system and looked at 520 norovirus outbreaks and looked at risk factors for those outbreaks. And he found that in 70% of those outbreaks, food workers were implicated. So food workers are a really important source of the virus. And in over half of those instances, there was bare hand contact with the ready-to-eat food. Now, some of the controls that are listed in the food code that directly impact or directly prevent norovirus contamination had already been in place when Aaron did this study. But keep in mind that there are key elements of the food code that address these specific issues, those being hand hygiene protocols, no bare hand contact, exclusion of ill workers, and a fairly new one, which is requirement for fecal vomit cleanup guidelines. Next slide. Okay, so what are some of the features of this virus that contribute to its high transmissibility? And this can be through food or through person-to-person transmission. And really the major ones are listed below on this slide. We have copious and prolonged shedding, low infectious dose, ease of transfer, role of vomiting, environmental persistence, and resistance. And I'm going to really quickly go over each of these with some illustrative slides. So the figure on the left here is actually the results from a human challenge study where people were intentionally fed norovirus, and we looked to see how often they got infected, how much virus they were shedding, and for how long. This was done by Robert Atmar and Mary Estes at Baylor College of Medicine. And bottom line is this: when you are in acute illness phase, you are shedding billions of virus particles per gram of fecal material. Okay? How much does it take to make you sick? Um, Somewhere between 10 and 1,000. I usually use 100 as my benchmark. How long do you shed virus? Well, you can see from the left-hand slide that you have a peak and then you have a valley. So you're usually, most symptomatic people peak at, at day 1, day 2, day 3 of infection, but you shed virus for a long period of time afterwards, albeit at much lower doses or much lower levels. In a different study, our group worked with Christine Moe at Emory, and we looked at how easy it is to transfer virus from hands, okay, in a challenge study. And the left-hand side, everywhere where you see a colored hand, that is an instance where there was detectable norovirus present on the hand of the individual who was infected. Okay, so it's super easy to transmit to hands. Next slide. Okay, I love this slide. This is fecal material at different in different weights. You start with 1 gram on the left-hand side and go down to 1/1000th of a gram. And I point out the latter two because at 1/100th of a gram or 1/1000th of a gram, you can barely see the fecal material, right? Okay. And yet they have greater than 100 infectious doses in that tiny amount of fecal material. So it doesn't take much to massively contaminate a lot of food or a batch of food that's being prepared. Next slide, please. Okay, vomiting is also a really important source of norovirus. And we don't necessarily think about this, but there are public vomiting events all the time. And we now know that in any one vomiting event that occurs in association with norovirus, about 1 million particles are released, okay? So that means that you have a lot of infectious doses being released. We also know from work that's been done in our lab, this is fondly called the vomiting machine, that that virus is aerosolized in the vomiting process. Okay. And what that means is that people can become exposed after a vomiting incident because virus is floating around in the air. Now, keep in mind, this is not a respiratory virus. They're not getting infected because they breathe it in. What's happening is they breathe it in and it hits the mucous membranes of the throat and the esophagus and then ends up in the stomach. But suffice it to say that vomiting is a source of viral contamination, both in the air for transmission purposes, as well as on surfaces where vomit particles may fall, which was, of course, illustrative in the example that Angie gave at the beginning of this presentation. Next slide, please. Okay, how persistent are these viruses on surfaces. So if you were to have a vomiting event or a fecal matter on a surface, whether it be food contact surface or a toilet seat, how long will they last? Okay. This comes from a paper that did many that documents many studies that have been done over time. The take-home message is that these viruses persist and remain infectious on surfaces for as long as a month to 6 weeks. So if you have a contaminated surface, that virus is going to remain infectious on that surface for long periods of time. If somebody were to potentially touch that surface and then put their hand in their mouth, then that becomes a source of exposure. Next slide. And this is actually illustrative of, this was a great study done by Ingeborg Boxman in the Netherlands, where she went in and did environmental sampling after norovirus outbreaks in some what they call catering establishments, which is essentially fast food restaurants in Europe. And if you look at the bottom part of that graph, you're going to see the percent positive samples that she got when she looked for evidence of norovirus. And for facilities that had an outbreak, upwards to 70% of the environmental samples were still positive for norovirus. So the virus was present on those surfaces. Next slide. Okay, what about surface disinfection? There's the CDC guidelines, which are kind of the gold standard in the United States and really internationally, is 1,000 to 5,000 parts per million hypochlorite, which is bleach. This graph shows some studies that our lab did where we looked at surface disinfection on stainless steel with 1,000 parts per million in the higher end, in the top graph, and 5,000 parts per million in the lower graph. And you can see that the virus was pretty relatively well inactivated at about 500 parts per million on clean surfaces. If you had a dirty surface, even at 5,000 parts per million, the virus was not inactivated or completely inactivated. Okay, so there's a couple of take-home messages here. The number one message is cleaning matters. Okay, you cannot disinfect without first cleaning. And if you come away with nothing else from this webinar, that is the message. Okay, the second is that 1,000 to 5,000 parts per million chlorine is a lot. In fact, on food contact surfaces, we're not even permitted to use those concentrations. And to be honest, most people would not want to use those concentrations because of odor and corrosivity issues. Now, there are lots of other non-chlorine based disinfectants out there. The most common other active ingredients are benzalkonium chloride and alcohols. Okay, bottom line is those active ingredients do not work against human norovirus very well. So if you're using those products that contain those components as the active ingredient, they're probably not disinfecting very well. There are a variety of other actives that have been looked at that are shown in red here. None of them really seem to work that well based on, sort of the standard usage of contact time and concentration. Some work better than others, but you cannot assume that these will eliminate the virus, and in some ways they might not even touch the virus. There are label claim issues, which is really it's too late for me, or it's too early for me. I don't have enough time, I should say that, to go into those details. But there are many EPA registered products that say they work against norovirus, but actually they don't. And there are some complex scientific reasons for that. Hand sanitizers are almost always either ethanol or isopropanol based. They too may inactivate some norovirus, but cannot be depended upon to inactivate, all. Next slide. Okay, so we're going to pop into what Angie's going to talk about, which is virus inactivation on surfaces. This is a great slide that shows the difference between cleaning, sanitizing, and disinfecting. I point out here, and you'll have access to these slides so you can read the details at another time, but there is no legal definition for cleaning. Angie's going to talk in greater detail about cleaning. There are legal definitions for sanitizing and disinfecting, okay? And basically, sanitizing really targets the reduction of bacteria, okay? And we're not talking about viruses, we're talking about bacteria, but it's not necessarily intended to kill all bacteria. Disinfecting will address bacteria and viruses with a defined degree of efficacy, okay? And but it doesn't necessarily kill spores. I want to say a quick thing about the well, let's go to the next slide and I'll say this. This is the last one. So this is sort of shows the EPA's hierarchy of products. So a sterilant addresses spores, okay, which are considered the most resistant. Disinfectants give a 4 log reduction of bacteria and greater than 3 log of virus, with norovirus and hepatitis A virus probably being the most resistant of those viruses. And then a sanitizer, a greater than 3 log reduction of bacteria on food contact surfaces. Now, if you look at how resistant norovirus is, it's definitely more resistant than what we call vegetative bacteria. And it's probably in the resistance level of bacterial spores. So that gives you sort of a hierarchy of where norovirus might fall relative to its susceptibility to disinfection. And with that, I think I'll pass it on to Angie.
Thank you, Leanne. Okay, so Leanne has shared a very brief overview of the science of what do we know about human norovirus. And so this evidence has been translated into prevention strategies. And so this has already been mentioned a few times during the presentation to date. And so in the FDA food code, there are 3 prevention strategies that are addressed in more detail in the food code. So personal hygiene, keep those hands clean, protection from contamination, which in this context, we're talking about cleaning, sanitizing, and when appropriate, disinfecting a surface, and then employee health policies. And so the focus of our talk today is going to be on the cleaning and disinfecting of surfaces. Next slide, please. So what is a clean surface? You know, this is very much more challenging than we realize. So as Leanne has already stated, there is no legal or universal definition of clean. It's not cleaning, it's not defined in the FDA food code or within the Code of Federal Regulations. So what a clean surface is highly subjective. We do have legal definitions that Leanne has already mentioned for antimicrobials, for sanitizers and disinfectants. So you do need to clean a surface before you treat it with an antimicrobial. And there are some exceptions, particularly in healthcare settings, where you don't need to clean before you use a disinfectant, but that's beyond the scope of this particular talk. So how do we monitor that a surface is clean? The most common way is visual observation. And that depends on if I'm wearing my glasses or not. You know, if I can see if it's dirty or not. And it varies widely by person to person. So it's a highly objective monitoring tool. ATP. But ATP has to be calibrated based on your operation. And so it does take some skill to come up with what we would call cutoff values for ATP usage, but it is widely used in larger food processing or food service establishments. Fluorescent markers, where you take a marker, and this is more for monitoring if people are actually cleaning the surface. You mark the surface, and it doesn't appear until you use a fluorescing light system to determine was that surface properly cleaned. And then the gold standard is microbial assessment, which is outside the reach of most retail food service operations because of cost and the time that it takes to be able to do that. So we often use visual observations to determine if a surface is clean or not. Next slide, please. So the other thing we have to remember is there's different types of cleaning. There's routine cleaning and deep cleaning. And depending on the type, it triggers what process do you use and what products do you use. So routine cleaning is simply, every day, you're removing food debris, from surfaces. And usually you clean the surface, AKA wash the surface. Then depending on if it's a food contact surface, you then treat with an antimicrobial. And in food service retail, that's going to be a sanitizer. Then there's what we would call deep cleaning, and this is event-specific cleaning, such as during an outbreak. You got to ramp it up, clean, and you typically are going to be using a disinfectant to try to eliminate as much of the agent as possible, or after a bodily fluid event. And think back to Leanne's slide showing the little plates of the fecal matter. During this time, you have to be very conscientious about cleaning, because not only can the virus persist, but a little dab will do you, essentially. And so when you're engaged in deep cleaning, also because you're typically using disinfectants, people need to be wearing PPE. Disinfectants are typically higher concentration of an active than as a sanitizer. And oftentimes you use specialized tools, such as, foggers, etc. Next slide. The other thing is when we're thinking retail food service, we typically think food contact versus non-food contact surfaces. But I also want to throw in another example. Hard surfaces, non-porous surfaces versus porous surfaces. And so you treat porous surfaces by immersion cleaning, 3-compartment sink, a dishwasher, or clean in place, where you're washing off the surface and then you spray it and then you wipe it down. Soft surfaces are under-recognized in the FDA food code, and we often don't think about those types of surfaces becoming contaminated. And this became very apparent during the COVID outbreak. So when you think of the FDA food code, most of the regulatory provisions focus on what do you do in the back of the house. There's very little references to the front of the house. And that's where you're going to find these soft, porous surfaces. And this can include, employee uniforms. It can include linens, napkins, wiping cloths, and upholstered furniture and carpet. And so think through, a hallmark symptom of norovirus is vomiting. There could be a lot of vomiting events that take place in the front of the house, on carpeting, on upholstered furniture. And the problem is think through the most common antimicrobial that's used would be chlorine bleach at 1,000 to 5,000 parts per million. That is going to oxidize the surface of those materials and degrade those surfaces. So it's going to be really important to make sure that you strategically select an appropriate disinfectant, particularly for soft surfaces. And actually, there are very few products available. And my colleague at Clemson University, her PhD student, David Buckley, studied the efficacy of steam. And we still believe steam is the best disinfectant on soft surfaces, because it doesn't degrade the carpet surface. Next slide, please. The other thing that we have to remember is high touch surfaces. And this became evident during the COVID pandemic. So high touch surfaces, are commonly touched. and by multiple people. And high-touch surfaces are often non-food contact surfaces. And so if you look to the right, I've given you some examples, touch screens, which are becoming more and more prevalent in food service operations. Dining tables, chairs, refrigerator doors, etc. Because these are classified as non-food contact surfaces, the food code only requires these to be cleaned, not to be treated with an antimicrobial. And so we also have to start thinking through how are we going to be treating these high touch surfaces. And if you remember back to the beginning of the COVID pandemic, which was almost 5 years ago, is we were recommending that all surfaces, initially the message was disinfect, and then the message was sanitize, because in food service, we typically use sanitizers. So I think that there's more work that needs to be done on how do we treat high touch surfaces. Next slide. So what do you do with all this information? We are very happy that you as educators are here to learn more about the science. So this is an example of a knowledge sharing model that I came up with colleagues at University of Arkansas. And so oftentimes we stop with if you look at the left side of the screen, we look at the research that's driving the messaging that we're sharing with you. And so oftentimes we conduct research, we generate messages, and that's it. But you as educators need to go a step further, because simply sharing knowledge based on high quality of evidence, which sounds great, does not lead to reduction of illness. What leads to reduction of illness is implementation of what you're learning in webinars like this. And so when you go out to train people, you really need to think through how can you motivate them to actually implement what you're sharing. And then I've got a couple of suggestions on the next 2 slides. Next, please, Katie. And so one common approach to training is we assume food safe or unsafe food handling practices is because people don't know. Trust me, I know what I'm supposed to do, and sometimes I don't do it for a variety of reasons. Oftentimes in training sessions, we dump a lot of information. It's an overload. And I think we're all exposed to information, and it's just an overload of information. So I think when you're conducting trainings or education sessions, be very targeted and focused. Also, we revisit a lot of what we call common knowledge. I have yet to be in a food safety training where they haven't told me to wash my hands for 20 seconds at least. Most of us know that, but why are we not washing our hands? It's common knowledge. So instead of just regurgitating that and moving on, think through why are people not washing their hands? What is it in the environment that's leading to them to not wash their hands? Because it's those factors that are going to lead to implementation. So I want you as educators to think a little bit more deeply, not just share the facts, but think through and include in your sessions, strategies for how you can get information from people as to why are you doing this? What are the barriers? What are the challenges? Next slide, Katie. And so the last thing here is, what is your role? Training outcomes. So people actually increasing their knowledge or their willingness to implement depends on a highly credible educator. And so attending sessions like this and learning more about the science is going to increase your credibility as an educator, because it'll allow you to present a strong argument rather than a weak argument. So if you're just regurgitating what you've heard and a person asks a question and you can't answer it, that's going to be viewed as a weak argument. And so I strongly encourage you to, better understand the science so that you can better communicate what is needed to decrease norovirus infections. And I do believe that the trainer activities need to improve. They need to include more understanding of the science. And so you need to know the current science so that you can effectively present messages. And so the skills that you need as an educator to reduce cases of illness attributed to norovirus include knowledge, good delivery strategies, get the audience involved, figure out, ask them what are the barriers, what are the challenges. And I think this is really, really important. understanding the industry. Many people have never worked in the retail food service industry, and there's operational practices that are counterintuitive to some of the messages that you might be sharing. So try to get a little, try to understand a little bit more about how the industry operates. Next slide. So the reason that we're here is because of the Norovirus at Retail Work Group. And so in closing, and I forgot to share a thank you slide, is that the Norovirus at Retail group, one of the projects that they're working on is they're creating a carefully curated repository of Noro tools that you as educators can use to reach various retail food service audiences. And we're continuing to work on this. And so hopefully sometime in the near future, that repository will be made available. So thank you. And as I said, I forgot to create a thank you slide. So I'm going to turn it over to Katie.
Thank you so much, all three of you, Angie and Leanne and Gina. So now we'll open it up for a brief Q&A, and I see there's already some questions in the chat, so if you haven't had a chance to get your question in, go ahead and do that now. And I'll start, this one's not necessarily specific to norovirus, but are outbreaks from tables and eating surfaces in restaurants considered foodborne for statistics purposes? And whoever wants to jump in with that one can go ahead.
I'm probably the most appropriate one to jump in on that. In large part, you cannot determine, or rarely can you determine if the source of an infection is a fomite, okay, so a contaminated surface versus a food. Really, in epi investigations of outbreaks, the focus is almost entirely on food, not on a potential fomite. To be honest, this is my personal opinion, that the likelihood that surfaces are a huge driver in the foodborne transmission is probably pretty low. So the answer is we talk about surfaces, and surfaces are important, but the reality is that the food handler really is the big driver here. It doesn't mean you shouldn't be sanitizing, right? Okay, or disinfecting. But if we can control the food handler issue, we will control a large burden of that illness.
And I'd like to just add to that, Leanne, is that probably you need to be most careful about treatment of surfaces after bodily fluid events.
Right, yeah.
That's when it's really critical. And I don't think we do a good job of that.
Yeah. And I do I think we should, there's enough comments here about disinfection. I think we do need to, I do need to clarify a few things on that.
Yeah, you can go ahead and do that, Leanne.
Okay.
Thank you.
Okay, so I can't go into details on the EPA licensing. Okay, I can simply say that because we don't cultivate norovirus, we use viral surrogates to allow disinfectants to make label claims. The surrogate that EPA uses is feline calicivirus, and it's extremely well known even by the agency that that virus is way more sensitive to disinfectants as well as to pH than is human norovirus. So many of the products on the market that say they work against norovirus with a 3 to 4 log reduction actually don't work against human norovirus. Okay. So, or don't work well against human norovirus, certainly don't give that 3 to 4 log reduction. Okay. And this is a problem. This is a problem because many people in food service, most of food service uses quaternary ammonium compounds, and quaternary ammonium compounds really don't work well against human norovirus. I wish I had a silver bullet. If I did, I would not be doing what I'm doing now. Okay. Because there isn't a silver bullet, which to Angie's point makes cleaning and prevention that much more important. if you don't have a good disinfectant, or you don't have an inactivation strategy, because these are ready to eat foods, right? Okay. Prevention and is where it's at. Keep it out of the food system. Do you have anything to add to that, Angie?
No, you did a nice job.
So, related to sanitizing and disinfectant, someone asked what could be used to sanitize or disinfect in homes? And a similar question, what's the ratio of water to bleach for home use?
Fine.
Um, uh, well, there isn't the ratio for if you have a clean surface, and this is based on research that we've done, I would feel pretty comfortable with 1,000 parts per million chlorine, which is I believe 0.1%. So that would be 1 in 1,000. Okay. With that said, that's a lot of bleach. I mean, you're gonna smell it. You're gonna smell it. And you would always, whether you're talking about home or food service, you're always going to clean before you disinfect, because any kind of organic matter will reduce the efficacy of pretty much any disinfectant that you use. I can't, I number one can't recommend a particular product, because for two reasons. First, I don't do that. I'm not allowed to endorse. And the second reason is there really isn't a product to to recommend. For home use, if you can look for a product that has hydrogen peroxide in it, peroxide does seem to have some efficacy against human norovirus, certainly, as well as bleach. But really, bleach is your best bet if you're in a situation where you can use it.
Well, and that's the important point, is if somebody should throw up on their couch, uh, people are not going to be using bleach at the concentration necessary to eliminate noro. And so they're going to just clean the surface without a follow-up antimicrobial treatment. And remember what Leanne had shared, low infectious dose, and it persists in the environment for a long time. And so there is more research needed to come up with non-damaging disinfectants that can be used after, vomiting, diarrheal events, particularly in home environments.
Yeah, and I would also say we're not talking about cruise lines here, but I mean, I think that is a concern
Mhm.
in those types of environments, that where you do get a soft surface contaminated, and then that just holds on to the virus for long periods of time.
Mm. So there was a question about steamers with soft surfaces. Do any If you don't have the answer to this, that's okay. Do studies show that household steamers, like for clothing or more specialized appliances like a little green, are effective at disinfecting? So are household steamers or specialized appliances like little green effective on soft surfaces?
Angie, I
They
leave that to you.
Okay, yeah, no, that David Buckley, he's the expert on steaming and disinfection. It's going to depend on the volume of steam and the temperature of the steam. So I believe that there are some domestic products that are capable of that. But again, they would need to be put on a list. I mean, so we can't make a blanket statement to say that all household steamers, can be used, after a vomitus or a diarrheal event in home. And the work that David when he was at Clemson, he used a commercial steamer. And he did show that contact time was 90 seconds or less. And he did believe that the contact time would be 30 seconds or less. He was doing some additional studies on that. And the contact time is really critical. And I just want to make one point, and Leanne, please correct me if I'm wrong. when you apply a disinfectant to the surface, you need to read the label because it'll tell you what the contact time is. And so what I noticed when going to the gym, people wipe off the equipment. A disinfectant must be wet on that surface for the time that's listed on the label. And that's one of the big problems is we often don't keep the surface wet because we're not using enough disinfectant. And that is critical for the efficacy of that disinfectant. So that's another little take-home message. Follow the label.
Yeah, and I'll tag team with Angie. Yeah, absolutely. And there are products that we've tested in the lab that if you allow your contact time to be 30 minutes, they
Yep.
actually work pretty well. The thing is that nobody is going to do 30 minutes. So it really is this combination of concentration and contact time. I do want to say something about wipes. I did not have time to talk about this, but the mechanism or the action of wiping is actually pretty effective. So the disinfection with a wipe is going to give you a different kind of efficacy than disinfection where you just flood something. Okay. Unfortunately, we don't have a lot of data on the efficacy of wipes per se, but our experience is that the wiping process itself removes maybe about 2 logs or 3 logs of virus, depending upon the design of the wipe. I do want to there was another question about children, and I really want to make an important statement about that. From an epidemiological perspective, in community transmission, children are considered really, really, really important. And those companies that are developing vaccines, the first use group that will be licensed to use these vaccines, and the vaccines probably won't come out for another 3+ years. Okay, it might be a little earlier than that. Young children are what they are being targeted for. So children are a major source of the initial transmission of the virus.
Yeah, thank you, Leanne. I was about to get to that question. So, I mean, this was a question about an acronym, I believe. What does ATP mean? It was mentioned under monitoring cleaning on a slide.
Do you want me to talk about that, Angie?
Yep.
So ATP is the energy molecule of all of our cells. And decades ago, very easy assays were designed where you could just do a simple swab and measure the amount of ATP that was present on that swab, which is indicative that you would have some kind of contamination with something that was potentially viable because it has to be made by something that's alive. And then that is used as an indicator as a very general indicator of filth. ATP monitoring is done very, very routinely in food processing, much less routinely in the retail food sector.
Okay, I think I'll pull one more question and then after that, I'll ask if there's anything you guys want to add before we close. So, this is related to hands. If bleach is the only way to kill the virus, how do you disinfect your hands or what do you do for hands?
You wash your hands. Yeah. Hand washing is very, 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 in fact, very, very, very effective. It is, especially if you get virus around the fingernails and around the nail beds. Okay, hand washing works, and that is one of the reasons why it is so important to. And we could get into a big discussion about hand washing compliance and the food code and why it's written the way it is. And but hand washing works. It does, especially if you after you use the bathroom.
Well, and I think to tag on to what Leanna is saying, scrubbing works. So think about what she had shared about the wiping cloths, the disinfectant wiping cloths, the disposable ones. it's a combination of the physical removal along with the antimicrobial. And so when you wash hands, there has to be friction and a scrub. And I think that that's a really important message.
Yeah. Yeah, and soap is really important. I mean, one of the
Mhm.
things that soap does is it loosens organic matter off the skin, right?
Mhm.
If you loosen the organic matter, the virus is going to be associated with organic matter usually.
Mhm.
That's going to increase your likelihood that you're going to remove. Same with running water. You use plenty of running water
Mhm.
because number one, you're not going to be contaminating all over the place, and number two, it helps with that removal process.
Mhm.
Fantastic. Is there anything either of you want to add? Anything you want to clarify? Or Gina, anything you want to jump in with before we close out the webinar? Final messages?
I just wanted to address one of the comments that I saw about point of care testing. It is true that the BioFire system, and I believe there's a secondary system, is used. And so there is more point of care testing than there has been. But in most communities, most community docs really don't do point of care testing. And a large proportion, and one of the commenters actually brought this up, most people don't go to the doctor with this.
Mhm.
Okay, so that really complicates getting accurate statistics on disease burden.
Thank you, Leanne. Angie, anything you want to add?
No. Well, actually, as educators, be challenged to figure out what motivates people. Again, it's not just sharing the facts, it's not just sharing what you know, but we need to motivate people to implement these practices. And that means when you're conducting training sessions or working with people, is having a two-way conversation, asking, okay, you need to wash your hands, why can't you? What are some of the barriers? People love to talk, and I think that you can generate some really good ideas from having those types of conversations during training sessions.
Thank you so much. That's a wonderful way to wrap it up, taking it back to the education piece. Yeah. So, just a couple quick slides as we close out the webinar. Thank you again to all of our wonderful speakers. I learned a ton today. I appreciate you. Um, if just final reminder on the CEUs, we will send those in an email. We'll post them on the website, so you will get those. You'll also get a copy of the slides and that follow-up email and the recording as well. A big thank you to our partners who help us keep these webinars free, and we're able to keep doing them. And that's it. Thank you for joining us, everybody.